Particularly in the community setting where you may be single coverage, you don't want to be doing procedural sedations for endoscopies if you're the only doc. You just don't want to do that. It's risky, for sure, and very time consuming, and then you're not paying attention to all your other sick patients.
Yeah, in the community setting, yeah, I think that's the other thing is you have to understand when you're on your own in a community hospital, and if you're the only provider who can watch your sedated patient, then anyone else who comes in is not seeing a provider until you're done with that procedure. Or you're leaving that sedated patient unattended when the code comes in or something like that. So you have to weigh those risks carefully. And I think especially in community hospitals, as you guys go out and you have to kind of get a lay of the land of what the relationship is with the ED and anesthesia, because all these community hospitals have different kind of procedural sedation battles that they've done. No one's done this in a standardized fashion. So anesthesia here, I think, is pretty hands-off when it comes to procedural sedation for us. But there are other hospitals where you're not allowed to use etomidate for procedural sedation at all. And anesthesia just says you're not allowed. And if you use it, then, and they're in charge of the sedation committee, so you can lose your privileges pretty quickly. So you just have to understand what that relationship is a little bit and play the game to some extent. So if anesthesia says you're not allowed to do procedural sedation except if they're ASA 1 and that's the understanding, then you call them up for all of them and just say, hey, I've got another one. And eventually they get tired of, and they'll give you a little more leeway. But you have to understand that, because if you exceed your credentialing, that's more than just kind of a patient care issue. That's an issue for your whole department, things like that. So you have to really understand what the agreement is and what you're credentialed to do. And if you're going to go beyond your credentialing, there has to be a really good reason to do that. And you need to at least have made a call to anesthesia with the understanding that, hey, I'm exceeding my credentialing, but I checked in with anesthesia. They can't do it. So I need to do this. This is if there are cases like that. So you just have to, and I think there's ASA, those are anesthesia guidelines. They don't make sense in the ED a lot of the time. So there's some really healthy ASA 3 people, but if you go down the list, and there's some people who clearly shouldn't be sedated. So you have to realize that there's some variation in that as well, and that the ASA doesn't really capture the immediate kind of ED instability of some patients as well. So there's some ASA 1s that I wouldn't probably want to do procedural sedation on in the ED, just based on all the other stuff that's going on. And there's some ASA 3s that I'd be pretty comfortable with. So you just have to kind of get a sense of all of that stuff.
So to summarize and close up so we don't go over too much, make sure you know what your local hospital is allowing you to do. It varies at every institution, and the rules can be very arcane about, is etomidate okay? Is ketamine all right? What about propofol? Like, it's very nitty gritty. Like, some places, nothing more than fentanyl and Versed. And I think that's crazy, but that's what the shop says. And you're in deep trouble if something goes poorly. And then, as Dan and Brad mentioned, making sure that you call anesthesia if you have any question about this, to at least have that extra layer of, look, if you can go to the OR with this, that'd be great, to make sure that you're utilizing your system's resources appropriately.
And for the graduating seniors, one little pearl of wisdom is that when you get done, practice with the herd at your community hospital, unless they're doing something that's blatantly wrong. Don't try to be crazy and go out and practice on either side of the bell-shaped curve. You want to be very reasonable, especially when you first get out of practice. When you've been doing it 30 years, like the Godfather, Dr. Janiak, do what you want. Otherwise, practicing with the mainstream, especially early on. Don't want to ruffle feathers.
All right. Thanks, guys.